Okay. All right. Thank you, everyone, for your patience. It's my great pleasure to welcome everyone to Lessons in Global Health, Learning from Each Other, Global South and the Global North. And we have a wonderful speaker today who's a very close colleague of mine, Dr. Mosopele, who's an associate professor of internal medicine and infectious diseases at the University of Botswana. He's also a research associate in the Department of Infectious Diseases and Immunology at the Harvard T.H. Chan School of Public Health. He obtained his Bachelor of Medicine, Bachelor of Surgery, and Bachelor of Biomedical Sciences at the University of Melbourne. He did his internal medicine residency at the University of Pennsylvania. He did his infectious disease fellowship with me during very dark days at Brigham and Women's Hospital and Massachusetts General Hospital. So we had many hours working together in our small fellow rooms in both institutions. And he also completed a Master of Science in Clinical Epidemiology at the Harvard T.H. Chan School of Public Health. So he went back to Botswana in 2015, and he has been both prolific, a leader in public health. He has more than 50 scientific publications. He served as deputy coordinator of the Presidential COVID-19 Task Force for the country, for which he received the Presidential Order of Honor, which is the second highest order conferred by the President of Botswana. He was served as acting deputy dean and of research and graduate studies in the Faculty of Medicine at the University of Botswana, and chairs the Department of Internal Medicine. So I am thrilled to have Mosopele here. Obviously, a very close personal friend of mine, but it's just been amazing to see him be a leader in global public health. So I am going to mute now and hand over.
Thank you very much, Ram, for that very kind. Those kinds words of introduction, and I apologize for the late start. I think my internet is not very good, but I'll try my best. And if you cannot hear me clearly or we lose the connection, just shoot me an email and I'll be able to try and get back on the call or the meeting. Today, and if your colleagues could just help to load the slides, I think that might.
What's there?
And as we're preparing to load the slides, I had initially, this thought I would share, stories around responding to 3 major diseases. But I think in the interest of time, I've narrowed this down to 2. And in my overview, which is the second slide, I'll share with you how Botswana responded to the HIV epidemic. And I'll start off by probably listing some key or notable successes, and then delving in to explain what it is that was done internally to result in those successes, and then some challenges at the end. And then number 2, I will talk about the more recent epidemic that we all face, which is SARS-CoV-2, and what Botswana did around that, and sort of draw parallels between some of the lessons learned with the earlier epidemic being HIV and the more recent one being SARS-CoV-2. And if you go to slide number 3, with the lovely lady holding a baby up in the air, I grew up in Botswana. I know how bad HIV was in my younger days. But in this slide, this is a report from the UNAIDS office, and released in December of 2021, right in the midst of another devastating disease outbreak, in which Botswana was being congratulated as being one of the first countries with severe HIV epidemic to reach milestones in the elimination of mother-to-child transmission of HIV. Around about the same time, on slide 4, the WHO also released a statement reiterating the same message, to say Botswana is now under 2% of mother-to-child transmission of HIV. which was a very remarkable story, given what we all recall in the 90s, where many children born in Botswana were born with HIV, and that led to the establishment of pediatric HIV clinic. And the future does not look like we will be setting up any more pediatric HIV clinics. In slide number 5, another key milestone, and this is very dear to me and always forces me to reflect on my experiences as an ID fellow in the US. And this is a slide from Statistics Botswana. It was published in 2022 in a national report that was very exciting, in which an internal survey in Botswana, which is done every 5 years to track and monitor our progress towards containing and potentially eliminating HIV, revealed that Botswana had attained the 95 targets for HIV as prescribed by UNAIDS. And you can see across those bars that literally on every key indicator, whether stratified by age and overall, that that survey revealed that Botswana has done remarkably well in containing the HIV virus and keeping many people alive. In the next slides, it is another major publication which really supports what I said earlier about elimination of mother transmission of HIV. And I just wanted to highlight that these are not reports from international agencies and or National Statistics Office, but also corroborated by peer-reviewed publications in medical literature. Now, I will tend to go through a series of things that I think sometimes as public health practitioners, we may not know about the real contextual factors that in any nation facing a major disease outbreak may actually put in place to try and help that response. And to lead that, in the next slide, I will really use first, before I add to this, a recent publication that was authored by several colleagues that I know very well from Botswana, especially the first author there, who has been a leader in prevention of cervical cancer amongst women living with HIV. And in the next slide, I just want to highlight that, before we think a lot about what steps we can all think of in terms of responding in any major disease outbreak, often there ought to be a process, a system, a structure in place, and a commitment in place to fund and have investment as a priority in health at the very highest level in a country. And Botswana was a very poor country at independence, but really early on, after gaining independence in 1966, a decision was made that the wealth that was generated from newly discovered diamonds will be put towards free education and a free healthcare system, which largely remains the same to date. And that is a very important thing in global health and medicine. And the next slide, again, when HIV was first reported in Botswana in the late 80s, and because there was nothing that people could use to save their lives, community workers went throughout affected areas, and they were very instrumental in offering palliative care because there were no therapies to treat people with HIV. And again, here you see community response coming out to assist in a major disease outbreak in the face of no other alternatives to save those who needed to be helped. In the next slide, when the first ARTs were licensed, AZT, in the late 90s, Botswana was one of the early adopters. And this was very deliberate and intentional in that in adopting a prevention of mother-to-child transmission of HIV for a population that stood under 2 million, people were very cognizant of the need to prevent this devastating disease from affecting newly born children so as to preserve the nation. So it was very strategic and intentional and not an accidental move early on in the beginning and the response to the epidemic. And the next slide, it highlights the very, very important role of political leadership in responding to global health public emergencies. In 2001, the then president of Botswana, who was the third president of the republic, took on the role of being the leader in chief in responding to the pandemic and addressed the United Nations. And in that speech, if you can look it up online, he basically said Botswana is on the verge of extinction. We've got less than 2 million people, and if we cannot get help to do this, the effects are going to be very devastating. So this was a very important move, a very important and strategic engagement at a political level. And you will see, as when I go on to the next slide, how repeatedly political leadership has played a very vital role in shaping and directing and making sure that the response has impact. Next slide. Having pleaded for access to drugs, having initiated AZT monotherapy to save children born from women living with HIV, Botswana then in 2002 rolled out a nationwide program to offer antiretroviral therapy. And this, in leading this, the strategy was very, very clear, and that the rollout had to happen in every community, and that it had to be led and guided by community members. As I said earlier, political leadership is very important. You can see that in 2003, under former President Bush, the establishment of the US government President Emergency Plan for AIDS Relief then really accelerated what nations were trying to do. And again, at a very high level, that is what sometimes makes a big difference to rollout of a program at a national level. And the next slide, again, you see that some almost 15 years later, the fourth president of the republic, following on what the third president of the republic did, decided to roll out a treat all strategy, wherein the country had made a decision that with a nationwide prevalence of 21%, if there could be as many as 100,000 people who are not suppressed, then we will never overcome the spread of new infections. And therefore, total community viral suppression as a strategy to prevent any new infection became of paramount importance 15 years after launching the first national ART strategy. And again, this was science-led, but fully supported at the political level. If you go on to the next slide, exactly 3 years later, after rolling out a treat-all strategy, again at the highest level of political commitment and appreciating and being very cognizant of the fact that when we have foreign residents living in Botswana and who may be coming in already HIV positive or acquiring HIV infection from citizens of the country, if our goal is to contain the disease, then we had to offer free antiretroviral therapy for foreign people living in Botswana. And again, this is a full extension of the 2016 Treat All strategy and the 2002 treatment strategy that had to cover all adults. In the next slide, we remain challenged, however, in our attempt to contain HIV, because one of the really stubborn and really challenging setbacks and challenges is stigma. Stigma continues to be a big challenge in Botswana, and it occurs in so many ways and so many levels. And it really prevents uptake of HIV testing. It prevents interest in PrEP because of all the stigma that is associated with HIV. And later on in this talk, I'll talk briefly about what led to some of this and how we can think through it to try and address it. In the next slide, I summarize some of the lessons that I think we learned in Botswana about how to mobilize and lead a successful and high impact HIV response. And as I highlighted, Botswana has only been gained independence in 1966, and we've only had 5 heads of states, and I have spoken of the third, the fourth, and the current fifth, all coming forward to provide leadership in an HIV response. And that's a very powerful thing, because that's what determines where resources go to in terms of national priorities. Lesson number 2 is social protection. If you recall, in one of my earlier slides, when I talked about new cases of HIV in Botswana, where we were for the first time having funerals and burials midweek. We do our funerals on weekends, but it changed at the very peak of the epidemic. But what made a difference was community mobilization, supported by a governmental response in the sphere of offering additional social protections. It is a very, very important thing. And I can tell you that often when I practice as a fellow in the US, it is one thing that I saw as a stark contrast between how we conceptualize social protection as a key component of rolling out global health responses. Now, the third lesson that I think is very, very powerful is the principle of disease containment that should be followed. With regard to HIV, if in Botswana it was largely a generalized epidemic, and it happened largely amongst heterosexual adults, then we needed to be very honest and focus on the right communities and allocate resources to those who carried the highest burden of disease in a community. And I bring this up because of the contrast we are going to have to make in a few minutes about how a disease that was seen to be within key populations in high-income countries, and the strategies that were placed in to contain the disease sometimes were not the most helpful strategies to try and take to other societies where the disease affected different populations. And then finally, one key lesson for me is that when we respond to epidemics as global health practitioners, we should never ever forget that, in the context of challenges, we should look for opportunities to learn and grow and invest back in the communities that we serve. And that with HIV now becomes, for Botswana, became how we responded to COVID-19. Because a lot of the infrastructure, the expertise that we relied on to respond to COVID-19 were things that we had learned from HIV. And also, what I said earlier about Botswana being small and fearful of, being eliminated by HIV, investing strategically to protect the next generation, because then we will have a future society, which is the PMTCT program, which predated effective rollout of our treatment to all adults. And the next slide, before I speak about COVID-19, I just wanted to close my few thoughts on how Botswana succeeded and what we may need as a path to HIV elimination, or very, very, very few HIV infections. I think right now, at peak we had 14 to 19,000 new infections per year. Now we are about somewhere between 7 and 9,000 infections per year. And they're generally affecting adolescents and young women. And therefore, if we are to conceptualize the HIV prevention strategies going forward in a generalized HIV epidemic, who should we be targeting? And I ask that question because I want to sort of pause and say, who has been the main target of HIV prevention strategies in high-income countries? And therefore, what biases should we be cognizant of and really proactively work to avoid because I think sometimes when we develop strategies for key populations in high-income countries, they're not necessarily going to be the same ones that we will need for adolescent girls and young women and some young boys. And second, where should we conceptualize these HIV prevention strategies to be? Earlier on, I said that we responded well in setting up services to offer HIV treatment. These were strategies targeting very sick people who maybe were more than many others willing to access the services in whatever manner we had packaged for them. Now, if we are to think of an HIV prevention strategy for people who are fairly mobile, digitized in 2023, who are well, and maybe there are perceived risk of HIV acquisition, I do not think using the same infrastructure that worked for us to attain such high viral suppression rates is going to work. Third, what should we be offering them? And I think this also might differ a little bit by context, because what maybe we offered, which was highly, focused HIV service, might not necessarily work for a generalized HIV epidemic where you are offering a service to people who are otherwise well. So we need to think of creative packages of services that we think would be attractive first to adolescent girls and young women. And then how should we do that? And again, as I said, this is a population that grew up in a different generation. And because they are well and are not seeking medical treatment services, how we offer this is going to have to be potentially a combination of very convenient services with some digital or digitization as part of the delivery strategy. And I think this is, for me, it's going to be a big challenge because we are asking providers and policymakers and even maybe political leaders who have never delivered services in the way that we think will be acceptable to the younger, more digitized folks. And in the next slide, I'm saying this because when you look at this slide from a UNAIDS report, Botswana national report, if you look at the prevalence of persons with HIV, let's take, for instance, the last two bars on the right. The dark blue is men who have sex with men. That prevalence is about 14%. The national prevalence is about 21% in the general population. And the prevalence amongst transgender people is, again, still less than 20%. And you can, from a disease containment strategy, this is a small population with a lower prevalence than the larger population, which has more potential to spread the virus should they have uncontrolled HIV. So I think our strategies here, need to reflect our challenges, and let us not be biased to think that, because of the heavy emphasis on certain groups in other settings, that that emphasis should probably be the same in some other setting where some people may not be the main contributors of the infection. And at this point, I will now switch to share a few thoughts about how Botswana responded to the SARS-CoV-2 virus in 2020. And this was the first major one that affected everyone in the nation since HIV. And as I did for my earlier comments about the HIV response, in the next slide, there is a recent journal publication, again led by a number of colleagues that I know very well from the University of Botswana, and they wrote a brief summary of how Botswana responded. I will add my own experiences as I was part of the team, but I thought it was fair to have an independent narrative from other colleagues. And we will see the similarities in the next slide. And in this publication, the next slide, please. In this publication, these colleagues start off by saying that the COVID-19 response was coordinated by the Office of the President. and that it was a multi-sectoral approach. And it is true, and it is very similar to how a similar structure was set up to contain HIV. It was multi-sectoral, and it was led out of the office of the president. And this task team in Botswana met once a week. It had almost 100, if not more, members. The representation ranged from the clergy, from political leadership, from senior government officials, from representatives of the private sector and business community, from academics, and all kinds of persons in society. And the idea was we needed to hear from all types of people in the country to shape a response that will hopefully be reflective of people's priorities and what they would be willing to tolerate as their own response. So that's how Botswana started it off. On the next slide, Botswana Constitution provides for the president to seek permission from Parliament to be given under the provision of the Constitution the power to make any decisions without seeking the approval of Parliament. It's called the state of emergency. So early on in the pandemic, I think this was in April or so of 2020, Parliament made this approval. And I'll tell you why this was very important in Botswana. It's a very consultative community. And if it were that you didn't have a state of emergency, the consultative process and value of consultation was probably going to harm the response. And therefore, if you knew that was potentially going to be the case, you'd probably seek, with taking the responsibility that you will not abuse this, but you will seek permission to be able to accelerate decision making without trampling on people's rights. And in the next slide, I'll share an example of how people's rights were curtailed to respond to the disease. And the first thing that was done was to divide the country into zones and then communicate how disease response will vary by the rate of infection per region. And I don't think you can guess how the zones were defined, but it was a very interesting way of defining zones in a country. Botswana is a cattle country, and well before HIV, Botswana was demarcated into zones for the containment of foot and mouth disease to protect the cattle industry and to separate cattle from wildlife. 40% of the country has been reserved for wildlife. So these zones are well known to everyone. And there are major highways and roads that connect these zones, and people naturally use those highways, which are gazetted points, to move between zones in their otherwise everyday life, pre-HIV, pre-COVID-19. So we literally went for the same zonal structure that is used to contain foot and mouth disease for cattle and was well known to everyone. And therefore, it made it very relatable to persons, even when they were told you could not move from this zone to the other. In the next slide, one of the things that Botswana did way early on and worried a lot about COVID-19 is we were aware, as we are coming together as a team, of what has happened in the past few years in terms of, news that are shared in all kinds of platforms that are not true, whether you call it fake news or misinformation, and how it can catch fire rapidly. And therefore, one needed to communicate and know what platforms to be present on and be there on time in a very timely manner. So in this risk communication strategy, whilst we targeted all kinds of media platforms, we had a strategy in place to also monitor what was being said so that we could, in a timely manner, counter things that we felt would be harmful to the response. We're mindful of the language in almost more than 90% of our national addresses. even if the presentation was written up in English, the oral delivery in, by way of speech was done in the local language. And in certain instances, we brought in additional communications experts to translate the messages to some other local dialects where, in a particular locality. So it was very, very important because like with HIV, often enough, you have nothing that you can give the population. But if you can get the population to understand your intent, your integrity, your consistency, then you can carry the community and the population along until you have effective interventions. And then they will be ready and willing to take up those interventions. In the next slide, it shows you some numbers that are extracted from the colleagues' same report. And it keeps going back to some of the things that I talk about. When Botswana rolled out a COVID-19 vaccine strategy, it was covered really well by the media. It was designed to be disseminated and amplified. And inconsistent with prior practice, where current or former political leaders are known to have a lot of authority and integrity and can be believed, the president who initiated the campaign against HIV and gave the 2001 speech at the United General Assembly was one of the first to be jabbed publicly to rouse confidence in the population that knew him to have led them through HIV. And you can see that we attained some of the highest COVID-19 vaccination rates of over 75, perhaps I think the highest in continental Africa. And again, the next slide, I summarize a few other things that my colleagues in the paper that I've been picking extracts from did not include, which is we attained some of the highest vaccination rates. We had one of the most robust SARS-CoV-2 genomic surveillance. Our testing rate was almost equivalent to some countries in Europe. Our surveillance team was the first to discover the Omicron variant. And this is the same team that had been doing viral load testing and doing HIV drug resistance testing and doing all kinds of transmission studies with HIV. So in terms of expertise and infrastructure, the experience from HIV in this sort of response came in very handy. And I move on to the next slide by saying the lessons learned are the same as what we learned from HIV, which is and consistent with what we did with HIV. Political commitment mattered the most. Social protections were key. People were given food packages in the event that they were of a circumstance where they could not get food because they were not able to go to work, or that maybe they lost their jobs. There were protections given to people to extend salary support even when their companies could not no longer give them a salary. So these things ought to be, we call them health responses, but they're a lot bigger than that. And that principles that should guide response are key and should always be followed to the letter and explained in a manner that the local population that one is dealing with can really understand, and also always look for opportunity to invest back, such as contributing knowledge to society by way of discovering a variant, which was really unheard of in this context for a small country of 2.3 million people. And the next slide, I want to share some additional insights that I think are really, really key in dealing with some of these global health challenges, whether in the South or in the North. And I'm reminded often with that first bullet of a book, one of the books that I read a lot as a medical student by Robert Putnam, Bowling Alone, in which he really talks a lot about how cohesion and sense of community declines in certain groups, and that is a problem, because when you have a catastrophe facing a community, you need people to come together and to work together towards a common goal. Because if you cannot, that will really neutralize your response. And that's one of the unique things that some of us were able to observe in the Botswana setting. Stability and non-violence is very key. I think probably there was one musician or artist who tried to sort of mobilize people to strike in Botswana, but that's the only one that I can think of. None of my colleagues who were part of the task team have never been attacked by anyone or received, well, I can speak for myself, I've not received a threat from anyone saying to me, why did you say this and not that about the vaccine or the virus? So it is really, a wonderful thing to witness how some of these attributes of nonviolence can really promote a more sort of rigorous and focused response without being, the digressions that one will have to deal with when there are other threats. Freedom of expression is very important, but as I said earlier, an effective, focused, preemptive risk communication strategy can effectively manage some of the challenges that sometimes comes with freedom for expression, especially if it's supported at all levels. And finally, as I said earlier, some of the key things in responding to epidemics is always see them as an opportunity to protect other members that you may need to maintain yourselves and your growth as a population, but also look for opportunities to train and or provide new knowledge. In my next slide, I basically ask the question, say, I know we are all global health practitioners, but we don't get taught some of these things, I think, well in training. And how engaged are we in recognizing, acknowledging that our political commitment is important, and therefore, when we shape our global health responses, to what extent do we put in a strategy to engage political leadership to ensure that the right resources, regulatory, legislative frameworks are put in place to be able to ensure that we get the highest impact from our engagements. Before doing COVID work, if you had said to me, go and engage with or brief a political leader, I would have said to you, I don't want to deal with politicians. I think I look at things very differently now, because I saw where that was done properly and how will it work, and where it was not, it really became a challenge to achieve response. And then the second one, which is social protection. To what extent do we as global health practitioners see the importance of a package that includes our diseases of interest and things that matter to people, that they need to survive, in our advice? It's very disheartening if you're in the middle of a COVID-19 response and you receive a call from a patient that says, I've been out of a job for a month, I'm going to stop taking these ARVs. And there I was trying to lead the COVID-19 response. So one always has to think, what are the other key social protection measures that I need to include as part of the package to roll out and high impact global health response strategy. And then principles of disease containment. I think for me, the classic example that I think we always ought to think of as global health practitioners was when I reflected on Botswana in 2019, saying even non-citizens, immigrants in Botswana will be given access to antiretrovirals for free. And that was not based on issues of race, it was not based on people's legal status in a nation, those were based on the fact that if those people lived with citizens of those countries, and then we have no other effective way of preventing them from interacting in manners that they may transmit the disease to each other, your only option as a global health practitioner is to recommend that everyone who tests positive should be given treatment to attain community viral suppression and limit the spread of the infection, period. It is not about the other issues. I think we ought to be very consistent with some of these things as global health practitioners, despite what we hear from others. And finally, I think I've spoken a lot about investments of all kinds that we ought to always remember as we shape. Never think it's all that gloomy. There's always something that can be learned and improved from a global catastrophe. Before I close, I'd like to thank all the patients that really help us to better understand the things we do, the family members and communities that give us a chance to do all the work we do, the governments that we work with, and the international agencies that help summarize and moderate conversations between nations about what we say about each other when a disease outbreak occur at one other country versus the other. You really get to value this, and I valued this a lot during COVID when I saw interventions by the WHO, for instance, about naming of viruses, or Botswana, discovering Omicron and being slapped with travel bans immediately when there was no suggestion that Omicron was a variant, such a very different variant compared to at least to Delta in terms of risk of immune escape. So we really appreciate the work they do, and many other private organizations that, for all the challenges and inequities that we face, the speed with which our work was done for COVID really speaks a lot to some amazing capacity that exists outside of what we do as academics or working for government institutions. And finally, big thank you to my mentees and my mentors who inspire me every day. And thank you very much for inviting me.
Thank you. So first of all, I just want to thank you again, Mosapele, for this talk. I hope everyone can hear me. What I was struck by is how you articulated a set of public health principles that really guide the broader thinking about how you should act, what you do, and how it cuts across diseases. And I feel like when you talk about learning from south to north, that's one of the things that I felt was lacking many times in our response to COVID-19 and to many other diseases. So anyways, I just want to point that out. I have a question to ask, but before I do that, the first person to the draw asked a very important question about PEPFAR and the debates around PEPFAR renewal that are going on in sort of our semi-functional US Congress. Could you talk to that and how much Botswana's programs are supported by donor support, how much of it is internally driven, and what it would mean if there were, for example, at any point, PEPFAR non-renewal? How would it impact people and services?
Thank you very much for that question. I am aware of the ongoing risk or potential shutdown of the US government. But like I said, political commitment matters. And it will always be controversial. But my take at the end of the day is it requires sustained engagement to see to it that things that public global health practitioners see as important, they lobby the right people, the right places to ensure that the required resources and support is made available to strategic global diseases that can potentially affect all of us. So I would say, I think PEPFAR was pivotal in saving many people and assisting many nations to shape the national responses. But it won't always be easy. I think it requires ongoing, never-ending debates and lobbying. And that's what's happening now for me. I think that's what it should be. Botswana was one of the first few countries that PEPFAR support was largely cut back because I think, and fairly so, I think the US government probably thought, for countries that were doing slightly better than others economically, I think it's reasonable to ask of them to also reflect and see how they can put resources into their response instead of eternally looking outside for support. And if you remember the rules around, for instance, PEPFAR funding, had Botswana been heavily and largely and primarily reliant on PEPFAR funding, I don't know the extent to which we would have unilaterally diverted the resources that we have in the HIV program to support the COVID-19 response. And so that's some of the benefits of being asked to shoulder your own problems. I think, I don't know the figures, but I want to say probably 80 to 90% or more of the Botswana HIV response is paid for by the government of Botswana. Thanks.
All right. I'm tempted to ask another question, but we're right at time. Can I ask it, Kim, or should I?
Go ahead, go ahead.
I'm going to ask it, and people can drop off as needed from the call or leave. But I sort of have this burning question. I'm going to take the privilege of asking it, which is that there's been a lot of debate, number one, around what happened with COVID in low and middle income countries. There were a lot of arguments at the beginning that COVID, quote unquote, doesn't matter because the age structure of the population is different, that these are younger populations, and various other arguments were made. And then I would add to that, then there's also oftentimes lack of clarity around how much mortality is elevated because of COVID-19. So I have very strong opinions about this, having seen the second wave of COVID-19 in India, which was very devastating, with 3 million people who died across the country within 6 weeks, with the Delta wave when it first emerged. But I'd be curious for your thoughts on this, Mosapele, having sort of helped to guide a national response, especially with regard to questions like, do lockdowns matter? Do they not matter? These were things that many people have very strong views vis-a-vis low and middle income countries. So I'd love to hear your thoughts.
No, thanks a lot, Ram. I think if I recall well, by end of 2021, early 2022, we had recorded cumulatively a little over 300,000 infections for a population of about 2.3 million people. I forget our testing rates, but the last time I computed it, it was the highest testing rate in continental Africa. So remember the entire COVID period, the debate around people getting infection or not, it was largely an issue of testing. To what extent was there a rigorous surveillance program, and what was the national testing rate? And so I accept that in probably most places, the numbers sort of were lower than what was probably happening on the ground. I also accept that, yes, in a relatively younger population where you test aggressively, you probably did not experience as many fatalities. For instance, in Botswana, we had about just 2,800 right about late 21, early 22. And that sort of fitted with what one would have expected for a nation with an average age of 24. And so you'd expect, when I compare to other nations, definitely fatalities in the order of 5% of those infected. And we were very rigorous. We tested almost everyone who died at that time. And, for me, basic field epidemiology, if you're dealing with something like this that kills, and if it kills in huge numbers, just go to the morgues. Just part of your response should be have the phone numbers of everyone who operates a morgue and drive to morgues and see what is happening, especially if it's a community where people are put in a morgue before they are buried. And so we did that to really sort of reassure ourselves that we were probably not missing some other COVID-related deaths that were not happening. So I think that for me, that was very, very important to do. And then if you are not so sure, go to burial places. And I've been, I cannot name them, I've been to countries that reported far fewer deaths than one would have expected due to COVID. But when you drive through burial places right in the middle of transit of COVID, you can judge that by the number of new burial sites. And then you know that is happening. So that really, really, really very practical field epidemiology sort of things you can do to assess what is happening. But again, these things that tough. I mean, the other one that really, if you recall, caused a lot of global concern was the availability of vaccines and what could have been done. And I remember looking at the numbers from Gavi and UNICEF in terms of how they were planning to distribute vaccines. And it was I think it came from a good place to plan to do that. But you found places like Botswana, if Botswana had signed exclusively to get vaccines from Gavi, it was less likely to get most of her doses at the beginning of the rollout. So then majority of the doses were then going to be delivered to countries that were not even ready to use them. And yet countries that could prepare to use the vaccines a lot faster, we're not going to get them. And then if you cost that, the unit cost of a vaccine relative to the cost of the vaccine rollout itself, you find after more than a year that actually now the rollout process will end up costing more than the vaccines themselves. So in Botswana, when we did the numbers and noted that, we then decided to go and do bilateral negotiations with major pharmaceutical companies because our vaccine rollout was going to be very expensive if we had waited for the small quantities that were going to be delivered through the multilateral arrangement. So there were sort of all these interesting things, but you just have to play along with them and figure out the best that might work for your context. Thanks.
Thank you. That was amazing. I think we'll have to close it at that. We're 5 minutes over, but I just want to thank you again, Mosopili. That was really outstanding, and it's really an inspiring example of how we should be learning globally from best practices, and it's really stunning to see Botswana's achievements, and it's something that we really could have used and learned from. I think many places in the world and especially in the United States. So thanks again, Mosopili.
Thank you so much for having me.
Thank
Good
you.
afternoon. Oh, it's good. Yeah, thanks.
Thank you, Ram.
Thanks, Kim.
Have a good day. All right.